Hello, and welcome to Spinal Muscular Atrophy, Improved Recognition and Management of a Rare Disease. This is the first podcast in a three-part series titled New Therapies, New Considerations, Supporting Comprehensive Coordinated Care in Spinal Muscular Atrophy. I am Vanessa Batista, Senior Nursing Director and Pediatric Nurse Practitioner at Boston Children's Hospital. And joining me today is Dr. Julie Parsons, who is the co-director of the Neuromuscular Clinic at Children's Hospital Colorado in Denver, Colorado. This program is supported by an educational grant from Biogen. Partners for Advancing Clinical Education is providing this activity for 0.25 ANCC and AAPA credits. To receive your credit for this program, please go to practicingclinicians.com/SMA1. I'll repeat that link for you at the end of the discussion. Today's learning objective is to explain the rationale for early initiation of treatment in SMA. So let's dive in. Dr. Parsons, can you briefly tell us about the genetic diagnosis of SMA?
Sure. SMA, or spinal muscular atrophy, is a neurodegenerative disorder that affects motor nerves or motor neurons. It's a genetic disorder that has an autosomal recessive inheritance. And that means that in most situations and most families, when a patient is diagnosed with SMA, there's really no family history of spinal muscular atrophy. Spinal muscular atrophy is an interesting disorder. On chromosome number 5, there are two genes, SMN1 and SMN2. SMN1 produces the major amount of survival motor neuron, or SMN protein, that nourishes motor nerves. So in patients who are missing the SMN1 gene, they have a marked deficiency of this protein. SMN2 is a backup gene, and we have various numbers of copies of SMN2. SMN2 produces about 10 to 15% of SMN protein. So if patients have fewer copy numbers, for instance, 2 copies of SMN, then they would tend to have a more severe presentation or earlier presentation of SMA. If they have 4 or more copies, they would tend to have a more mild phenotype.
Thank you so much, Dr. Parsons, for that overview of the genetic diagnosis of SMA. Could you also talk a little bit about some of the clinical findings on exam when you're seeing a child and making a diagnosis?
Absolutely. And I think it is important to remember that we still need to look at babies clinically. Although we now have newborn screening won't pick up every baby with spinal muscular atrophy. And in some states, newborn screening isn't available. So when we see a young infant or a baby with SMA, there are a couple of physical exam findings that really stand out. One is that the baby is a floppy baby, that they tend to be weak and floppy. When you pick the baby up, they tend to kind of run through your hands a little bit and don't have the ability to really steady their muscles. They have very poor head control. Some babies will have retrognathia, or poor development of the chin and jaw. As you open their mouth, some babies will have tongue atrophy and fasciculations, although fasciculations are sometimes a little bit difficult to recognize in a newborn. One of the things that we see most prominently is an unusual breathing pattern in these babies. They have what we call paradoxical breathing, or belly breathing, where we see their abdomen and belly come up and down. Their chests tend to be tiny. We describe them as bell-shaped chests with poor lung expansion. So they tend to use their diaphragm, which is a muscle that's spared in SMA, to help them with breathing. When a baby is significantly weak at birth, they may have flexion contractures at their joints. So that's an important thing to look at, is range of motion of all of the joints. They also lack reflexes. So when we're testing reflexes, which again, some people find a little bit difficult in a newborn, but they don't have any deep tendon reflexes or muscle stretch reflexes. One thing that's very important to remember about children with spinal muscular atrophy is, as I said, this is a disorder that affects only the motor nerves or motor neurons. So these babies are very bright. There is no encephalopathy. There are no thinking problems that go along with SMA. We also don't see any changes in terms of their eye movements or fluidity of eye movements. So they can track, they can hear, they're bright, alert, and typically have great visual attention. Again, this is a disorder specifically of the motor nerves or motor neurons.
Okay, great. Thank you so much. We've seen so much growth and expansion over the past few years from a testing perspective. Can you tell us a little about how newborn screening for SMA started and evolved in the US?
So newborn screening for SMA really started with pilot programs that were looked at because we had development of some wonderful treatments for SMA. In 2018, the suggestion was that SMA be added to newborn screening across the United States. So the Secretary of Health and Human Services signed on to the recommended uniform screening panel that SMA be tested for in all states. Every state has to develop their own newborn testing program, however. So it's taken a number of years before each state has programs for newborn testing. And most recently, I believe all but 2 states now are able to add SMA to newborn screening. And we're covering about 98% of newborn babies born in the United States. In order to have a newborn screening program, we do have to have a disorder that can be easily diagnosed, and SMA fits that bill. And there has to be a treatment that helps pre-symptomatic children to have better outcomes. And we currently have 3 FDA-approved therapies now, all of which can be used in pre-symptomatic babies, making newborn screening absolutely ideal for this particular disorder.
Great. We've certainly come a long way in that regard. So we've just covered genetic testing and newborn screening. Let's talk a little bit about what logistic considerations there are when you receive a positive test result in your practice. What next steps should be taken?
So when a baby tests positive for SMA through the state programs, through newborn screening, the process is a little bit different in each state, but there is a call that goes out to the provider, pediatrician or healthcare facility, saying that there's a positive test result. I should mention, because this is very important, that newborn screening really only picks up about 95% of babies with spinal muscular atrophy. There is about 5% of a little different genetic composition in those babies that makes it harder to diagnose on newborn screening. But 95% of the time, we're able to diagnose these babies with SMA. We then will see patients very quickly, typically within 24 to 48 hours, and definitely have our genetic counselors involved in this process. As I mentioned, this is a surprise to patients and families that they're diagnosed with SMA. When the babies are then seen and examined, the families understand and hear about and are educated about spinal muscular atrophy, as well as the 3 potential treatments that are now FDA approved in the United States. We do consider treatment of SMA an emergency, and we try to get all babies treated as quickly as possible. We know that there is decline in the population of motor neurons, maybe even as much as 50% before babies with SMA are even born. So the more time that goes by, the more motor neurons are going to be affected, and we can't really replace motor neurons once they die or degenerate. So we do consider, again, urgent treatment for SMA to try to halt that process and give babies the best outcome possible. It takes a little bit of time to do some testing. We do some baseline laboratory testing. First of all, we want to confirm this diagnosis, so we will repeat the genetic testing and we will look at the SMN2 copy numbers. As I said, this gives us information in terms of what we expect for the baby to look like over time. Fewer copy numbers, for instance, 2 copy numbers of SMN2, those babies get weak very, very quickly. Whereas in general, babies who have 4 or more copies will have symptoms that appear a little bit later on. If families are interested in having gene transfer therapy, we always do antibody testing to see if that drug treatment is a possibility. And we then begin to look at getting insurance authorizations to be able to treat babies quickly. I think across the United States, the majority of us target trying to treat babies by 21 days of age or so that we can give them the best possible outcomes with early treatment.
Great. Thank you for talking with me today about this important topic. And thanks to everyone for listening. To claim your credit for participating in this activity, please go to practicingclinicians.com/SMA1 and complete the post-test. Again, that's practicingclinicians.com/SMA1, and that's a numeral 1. Thank you. I would also invite you to listen to the 2 additional podcasts in this series where we discuss medication therapies and coordination of care. Thank you again for joining.